To kick off the morning, we have Professor Louise Newman, and I'll just tell you a little bit about Louise. She is Professor of Developmental Psychiatry and Director of the Monash University Centre for Developmental Psychiatry and Psychology, and Chair of the Detention Expert Advisory Group. In January 2011, Louise was appointed as a member in the General Division of the Order of Australia. She's a practising infant psychiatrist, and she's currently focusing on the evaluation of infant-parent interventions in high-risk populations, the concept of parental reflective functioning in mothers with borderline personality disorder, and the neurobiology of parenting disturbance. Louise has been very supportive of the trauma-informed care and practice agenda, and she spoke at our forum last September, so I'm very pleased to have her back with us for this conference. Thank you, Louise.
Thank you very much, and thank you for inviting me to what I think is such an important meeting, following on from the initial meeting where some of us we were really privileged to be able to get together and talk about the importance of trauma-related issues and approaches, and this is a fantastic next step, and I heard very good reports about the significance of the issues that were spoken about yesterday. So I'm very pleased to be here and give maybe a bit of an overview of some of the work and thinking that's going on at the end of the lifespan that I work with, which is mainly with the very young, and in the whole area of so-called early trauma and developmental psychopathology. So in practice, most of my work is actually working with parents who themselves have had histories of difficulty, from maltreatment to neglect to frank abuse, and some of the challenges that raises for parenting. And I think I should say at the outset that this is a very misunderstood and I think misrepresented group of parents. Many of these parents, of course, are acutely aware of the difficulties that they faced, highly motivated to parent in a positive and effective way with their own children, and often acutely aware of the difficulties that they have as a result of the legacy of trauma that they've experienced in their lives. And we know that these are parents who frequently intersect with a range of systems in our community, whether it's child protection, whether it's family support services, mental health services and so on, not many of whom, from my perspective, are oriented to thinking about the challenges of parenting, the challenges of being an attachment figure, and how transformational that experience can actually be for people who've experienced maltreatment or neglect. So it's a crucial period, I think, in which we as clinicians, researchers, service providers need to be thinking about the challenge of helping people actually parent effectively in the way that they would like to, and also to understand the potential barriers that they might face in that endeavour. So my personal view, just to state it, which is probably preaching to the converted here, obviously, and that we share a common interest in these issues, is that we fundamentally need to have a very clear trauma-focused and developmental framework when we're approaching these sorts of issues. We need to understand the reality of the long-term issues that can confront people who've experienced childhood trauma and abuse. We also need to think in a much more reflective way about our communal response to that, how we as a society and a community think or don't think enough about trauma. My other area of work, as you're probably aware, is with asylum seekers, and I have to get it in somewhere today. But this is the brutal reality of trauma, and in this case, trauma inflicted by government, and we seemingly have a collective blindness to actually being able to raise that as an issue. We have at the moment a government prepared to re-traumatise children by sending children, some unaccompanied, to Malaysia to conditions where they will be persecuted and tormented. Now, this is unacceptable, and I think a group like the group here today, if we're focusing on trauma, then we're thinking about trauma in all its manifestations. So these are very complex issues. These are issues that are often put into the too hard basket. It also means it's very hard not only to get services and government to listen, it's very hard to get funding, it's very hard to do research in these areas, as I struggle with all the time. So it's a conversation that we need to be having. So how do we do that? How do we actually bring trauma to the fore in our thinking? And I guess hopefully as we go through today and have discussions, we'll come up with some ideas about that. So when we're talking about infants and parents, we're talking about some of these very early interactions. This just happens to be rather a nice depiction of a very positive encounter between a young child and a primary carer or attachment figure, the mother in this case, and her capacity to be with that child. Many of the parents I work with who've had huge amounts of early trauma themselves struggle with how to do that. They might, of course, want to change things that have happened, don't want to repeat with their own child what happened to them, and often are very clear about stating that right at the beginning. And yet as service providers we sometimes say, oh well, that's unlikely, you don't really need support, you're aware of the difficulties, we'll leave you alone. And maybe that's not the appropriate way. Maybe that's minimising and not engaging with parents with their very real anxiety. How can I effectively parent in the face of my own history? Or how to put my own history in its place? And what sorts of interventions and supports help parents who've had these experiences live with the reality, understand the reality and its impact in a way that allows them to think about protecting their own child. And I think this is the dilemma that we face when we think about the transgenerational transmission of trauma. We know it's not universal at all, but we certainly know that when it happens it can be extremely quick without thinking and a very powerful repetitive dynamic that some people face. So the people that I see are probably this age, very, very small, with rapidly changing needs, rapidly changing emotional states, very good at communicating emotional states. Those of you who've had babies or work with babies, you'll know how quick they are, how they can move from one state to another, and how the job of the parent is fundamentally to read that, interpret that, and then to do something about it, to help that child deal with their own anxieties and states that at that age, of course, they're not able to fully regulate. Some of the very deprived parents that I would see are very puzzled when it comes to being able to know how to respond to things at that level, at the level of emotional interaction. And in many ways we know from a research perspective something about that part of the legacy of early trauma can be confusion and difficulty in managing emotional states. And that makes it very difficult for some adults who've survived early trauma to actually regulate their own states, but also to read and process communication from others. So when we think about the legacy of trauma at the level of interpersonal interaction and relationships, and that's fundamentally important. And of course that impacts parenting, where part of the job, of course, of early parenting is very much to be an active reader and processor of these sorts of states. So what we're trying to understand in my unit and the field in general, I guess, is how we understand the long-term impacts of psychic trauma, how we relate that to current, I guess, definitions and categorical approaches to thinking about things that we call personality disorder is a pretty complex issue. My personal view, and I know you've had some discussions about this yesterday, is that the term personality disorder is often used in a very unhelpful and pejorative way. It's not necessarily very helpful in terms of anyone understanding the difficulties and real challenges and lived experience of people who've survived trauma. I sometimes use the terminology in the diagnostic sense, but only very much as a shorthand, and I don't think it's a particularly useful framework as it stands for thinking about trauma and its ramifications. So there are very good arguments for dispensing with the terminology altogether and talking about responses to trauma, talking about complex and ongoing responses to trauma. But my work is fundamentally trying to understand how these overwhelming experiences, at whatever age someone might have them, whether it's a 6-month-old baby, a 6-year-old child, a 16-year-old, how trauma in the broad sense can overwhelm people's capacity to manage at that time. And that can set off a train of effects, if you like, or secondary effects that can be very disruptive to ongoing development and later psychological health. So the very young that I see who are in troubled relationships where parents themselves might be troubled, depressed, anxious, sometimes very ambivalent about having a child or even angry sometimes, difficulties with their own feelings, are infants who can be developmentally compromised at quite an early age. So a lot of my work is trying very much to think about what does early intervention really mean? How early should we be intervening? How early should we be trying to identify parents with histories of adversity who might be having difficulties potentially, even if it is only potential, in terms of parenting? And how can we better assist those parents in a respectful way to deal with their own history of trauma and move on from that to be the sorts of parents they would like to be? So that's really the whole very political question at the moment of what constitutes early intervention. We know that a lot of the discussion at the moment is about getting services in place for adolescents and young adults, and of course they need services and supports. No one's going to seriously argue that they shouldn't have them, but it's the and question. That's all well and good, but what about the very young? What about earlier intervention? What about intervening early in the lifespan, as early as we can? What about some of the work that I would do talking to women contemplating pregnancy or women who are just pregnant, who want to think about being a parent given that they've suffered early abuse and trauma themselves? These are very real and very important questions to be asking, and yet if we talk to particularly to funders at the moment, that's probably not seen as high priority. So my personal feeling is that we should try and reclaim the term early intervention. Treating adolescent onset of established conditions is treatment. That's not necessarily prevention, sadly, but I like to think that we can orient ourselves in the trauma field to doing more in the way of true early intervention, prevention of some of the more complex responses to trauma. Children who've been traumatised and abused need interventions at that time. It's not just about risk identification, it's not just about providing a system of alternate care. It needs to be therapeutic care. It needs to be care that actually helps children at the time who are experiencing trauma-related symptoms, which they are, even if they're babies. So I would see babies as young as 2-4 months of age who are already showing signs of trauma, given those in very extremely high-risk situations.